Hello, everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled Optimizing Urinary and Sexual Function After Chemo, Radiation, and Surgery. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients and caregivers and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature that you can find at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not get to every question today, but we'll answer as many as possible. Dr. Jennifer Linehan is a board-certified urologist and an associate professor of urology and urologic oncology at the St. John's Cancer Center in Santa Monica. She completed her medical degree as well as a general surgery internship and urology residency at the University of Arizona, where she also received the George M. Drach Award for the most compassionate urologic resident. She also received awards for her research in diagnosis and management of kidney cancer. Today, Dr. Linehan is an experienced robotic and laparoscopic surgeon. In addition, Dr. Linehan has been involved in prostate cancer research and identifying biomarkers for this disease. She has authored papers, presented abstracts at research conferences around the world, and continues to dedicate time to both basic science and clinical research. Dr. Linehan is certified by the American Board of Urology and is a member of the Society of Urologic Oncology, American Urologic Association, and Western Section Urologic Association. It gives me the greatest pleasure to introduce Dr. Jennifer Linehan. Dr. Linehan, please join us.
Thank you. Sorry, there you go. Hi, everyone. Hope you're doing well this afternoon. I am going to share my screen really quickly. So you guys can all see my talk. And here we go. Okay, so I'm Dr. Linehan. I'm a urologist at St. John's in Santa Monica. And one of the things that I found in my own practice is that the patients come to see me, we do all our cancer care, we get through their cancer care, and they're often left with things that affect either their urinary quality of life in my business or their sexual function. And sometimes during the treatment, we're not talking about those things or thinking about those things as much as we are about treating the cancer. And so we're left in a position where the cancer's gone, but they want to have a better quality of life. So I wanted to go over some of the things and the treatments that we have available and the different problems that I find that patients are dealing with in my own practice and in other specialties, even in gynecology, as well as other men's health issues that the patients may be dealing with, both men and female, and try to go over these and offer some tips that you might want to talk to your doctor about, or you might want to find a specialist about that might be able to provide care for you and give you a better both urinary and sexual function and quality of life. And I find they often go together. So what really interrupts sexual function for patients? One is pain. Sometimes patients will have had radiation or surgery that will cause pain. Patients can have dysfunction like erectile dysfunction, or they can have vaginal dryness that can cause dysfunction, lack of sensation. Sometimes if they've had radiation or chemotherapy, the nerves have been damaged, and even surgery that can also cause some lack of sensation, changes in libido, and a lot of that may be hormonal, especially if you've had a gynecologic cancer or a breast cancer or a prostate cancer. You may be treated with different types of hormone therapies, or giving you hormones may be restricted, and that can also lead to interruption in sexual function. It can lead to changes in your libido and your sex drive. So all of that can be very different. And then changes in your urinary and bowel function. If patients are leaking or incontinent, or some patients will have fecal incontinence, that's going to change their sex life because they're not going to want to have intercourse if you're leaking urine. So I think all these things go together, and sometimes more than one of them are happening, and sometimes just one. And here's some of the things that we can do to help patients get back on track. So pain for me is one of the hardest to address. I feel like I often will see this in patients who have had radiation, or radiation then surgery. A lot of this can be just vaginal dryness and just providing lubrication. I mean, even men in the penis does secrete like mucus and has glands to help with lubrication. And if the man has had prostate cancer or radiation, those may have been damaged. And so I think having a good lubricant, and there's multiple types. Some of my patients love coconut oil. Some of my patients love a brand called Luvena. Mostly I would recommend a water-based. That's usually the safest and the cleanest. But I think that's always a big issue with both men and women. Pelvic floor therapy. So just like the muscles in your body have a layer of fascia around them, and people go and get a massage when they have muscle pain, you can actually do pelvic floor therapy to release the muscles in the pelvis, because those muscles also have a layer of fascia that can get contracted down over them if you've had surgery or radiation, that can tighten around the nerves in your pelvis and cause discomfort. So pelvic floor therapy is a very personalized and different kind of physical therapy than other therapies. A lot of times there may be some manipulation. For women, the therapist may actually put the hand in the vagina and work through the muscles. And for men, sometimes they may put a finger up into the rectum. So it can be a very personalized therapy, and that can branch from that kind of manipulation all the way up to like just doing some yoga exercises to release different parts of the pelvis. They can use TENS units. So there's a variety of things that they can do, and that can often really help with pelvic pain and also with urinary issues, and even help with erectile dysfunction. So pelvic floor therapy, it has a wide variety of uses, and I often find that if I can just get the patients there, it really does help. I am a firm believer in acupuncture, especially for all kinds of pain. I've seen this work with patients over and over again. Now you do have to be consistent with it, meaning that you've got to you've got to go to an appointment at least once or twice a week, and oftentimes insurance will actually pay for it. So I really am a firm believer in acupuncture. Pudendal nerve injections. So there are nerves in the pelvis, and just like you can sort of get an epidural for back pain, you can do the same thing for pelvic pains, and you can do what we call pudendal nerve injections, and it basically numbs the nerve, the pudendal nerve that's largely responsible for sensation throughout the pelvis, both in the male and in the female. And then actually Botox. Botox can help with pain as well as urgency and frequency in the bladder, and even some radiation issues in the vagina. Oh, sorry, I'm going the wrong way. Okay, so again, pelvic floor therapy, exercises that help promote flexibility and release nerve entrapment. It increases blood flow to the area. That's actually how it helps erectile dysfunction. It promotes relaxation of the pelvis as well as strength. So sometimes the muscles are too tight, causing pain, and sometimes they're not tight enough, which can cause incontinence. So true pelvic floor therapy is actually learning both. And then you can use it for incontinence, penile rehabilitation, and sometimes vaginal discomfort. So what are pudendal nerve injections? So again, the pudendal nerve is a very important nerve. I don't know if you guys can see my cursor here that runs through your pelvis. And in women, it goes to the vagina, and men, it goes to the penis. And it also goes to the skin all around that area. And so if you have a patient who's having chronic pain in that area, again, that could be from radiation, from surgery, from chemo, from everything all together, you can do, just pudendal nerve blocks, which is usually with lidocaine. Sometimes you can mix lidocaine and a very low grade or low dose steroid, and you can actually inject the nerve. And the nerve and where you do those injections is almost sort of in the crease of the groin on both the man and the woman. And this can be really helpful for some patients. And I've even seen it used in patients that have some sciatica. You can do, because the sciatic nerve is actually very close to the pudendal nerve too. And that can be very, very helpful. And typically for most patients, this is something that you can do in the office. Often a gynecologist can do this, urologist can do this. And I have some really great, doctors who are actually neurologists and pain specialists that can do this as well. So let's talk a little bit about female sexual dysfunction. So what I'll see in my practice is patients who have had surgery, radiation, chemo, and some combination of the above. And surgery can actually cause a shortened vagina. And of course, that will cause sexual dysfunction. Radiation can cause dryness, tightening, loss of elasticity in the skin, bleeding and nerve damage. And then just in general dryness, like we talked about before. So what can you actually do for a shortened vagina? We had an interesting case not too long ago here. Patient was a 34-year-old that had to have a hysterectomy and radiation, and the vagina became so shortened she was unable to have sex. She's 34 years old. So there's actually several techniques where you can use skin and tissue from the abdominal wall. You can use bowel, and you can even use what we call an allograft from bowel to actually recreate the vagina or lengthen the vagina in some of these patients. So there are surgical techniques and things that can be done if, maybe a woman's unable to have sex because of this issue. And again, we don't, talk about it very often. And I find patients are sometimes embarrassed, but these are things that you should be talking with your cancer surgeon about. And because they can find ways and specialists in reconstruction that can really, really help with this. What about radiation damage? So I will see patients come in that have bleeding from both the bladder, bleeding from the vagina, bleeding from the rectum, and it's all from radiation damage. And often what you'll see for example, in my world, I'll see patients that have bladder bleeding and from radiation. And, in the first beginning, when they get the radiation, they don't really notice anything. But then as weeks, months, and years go by, the radiation damage may start to set in, and they start getting these sort of dilated blood vessels in the bladder. Well, these dilated blood vessels actually are very fragile and can rupture very easily, and then they'll get bleeding. You can also see things in the vagina and rectum of this sort. And one of the best treatments for this, and it's been incredibly successful, is hyperbaric oxygen. Now, most people will think of hyperbaric oxygen or oxygen tank from knowing people from going scuba diving when they get the bends. But this is a little bit different. And there are generally two types of tanks. So the first tank I have pictured here is where you sit in the tank with multiple people and you can watch TV. And you usually have to do this treatment like every day or, once a day for 5 days for 41 treatments. And you have to sit in the tank for about 2 hours. And they basically decrease the pressure. So it's almost like you have to adjust your ears or pop your ears or squeeze your nose, almost like you were scuba diving. Then they keep you at that depth or that atmospheric pressure, and then they slowly bring you back up. Now, sometimes patients will prefer to go into like a tube that's a clear tube so they can kind of see out, but it's personal. They're in it by themselves. So there's multiple machines. There's multiple hospitals that have this technology. There's usually a very specific hyperbaric medicine doctor that also does this. And if I have patients that are having bleeding or severe pain, actually insurance will pay for it. Again, it is time intensive for patients because you got to show up, you got to sit in the tank sometimes up to 2 hours a day. But I think the results are incredible for patients, and they have a lot of regeneration of the tissues that have been damaged by the radiation, making them more elastic. So this can really help with sexual function and with pain. Okay, so we talked a little bit about dryness. There is a couple of other things you can do. So I will have patients start taking omega-3 oils that can help with vaginal dryness. There's, like I said, multiple different lubricants, and there is a vaginal laser called the Mona Lisa. In fact, it was built really for vaginal dryness. The importance of the laser is that if you are a patient that's had breast cancer and or a gynecological cancer, uterine, ovarian cancer, where you cannot take any vaginal hormones, that is where the laser can be helpful because it actually encourages collagen production and encourages the blood vessels to grow back. And that can be very helpful in aiding the dryness. So you can also use a lubricant. Hormones are probably one of the better treatments for vaginal dryness and also for libido and dysfunction, but that is really got to be a good conversation with your medical oncologist and your surgeon before we initiate you on hormones. I will tell you that in my practice, even patients with breast cancer, oftentimes I can use a little bit of vaginal estrogen to help with dryness because oftentimes the vaginal cream is such a low dose that it's not really affecting the whole body systemically. It's just more so staying in the vagina. And I usually will call the medical oncologist or the surgeon and be like, hey, is it okay if I use estrogen in this patient? And sometimes there's combinations with progesterone and even testosterone creams. For men, we're learning more and more now that even if you've had prostate cancer, treatment for prostate cancer, giving men testosterone replacement is not as dangerous as we thought it once was. So testosterone is the fuel basically for prostate cancer. So shutting off testosterone makes prostate cancer die. Giving testosterone can make it grow. But if a patient has had radiation of the prostate or a prostate removal, there are some instances where you can actually replace the testosterone in those situations without causing any harm. And we're doing, like I said, there's more and more evidence and data and studies around this where you can give the testosterone safely to some of these patients, and that really can help regenerate their sexual function, their sexual activity, their libido, everything. And women, it's very, very similar. But again, that has to be a conversation between, your medical oncologist, your surgeon, and maybe the doctor who's treating the dysfunction. So what about male dysfunction? So male, we generally see erectile dysfunction, and the other one is retrograde ejaculation. So erectile dysfunction is basically where the penis no longer fills with blood in order to get erect. And we can deal with that on several different levels. Retrograde ejaculation is where the semen either doesn't come out or goes back into the bladder when the patient is ejaculating. Now, in general, that's not a bad thing, unless you're trying to have kids, but it does cause some, sexual dysfunction for men if that's happening. I will also see, patients that have had maybe rectal cancers, prostate cancers, urologic cancers, radiation. Because of those, the tubes that carry the semen and the sperm can get sort of scarred down, and they won't make as much fluid anymore. And so they may not be getting as much fluid out. So those are all things that we can try to deal with and try to help that can make their, sexual function and their quality of life better. So what do we do for erectile dysfunction? Well, every day this field is growing, and there are more and more things that we can do for men. So everybody usually knows the basics. First are the medications. So you give Cialis, Levitra, Viagra. And what these medications do is help to open up the blood vessels to allow the blood to come in to the penis and make it erect. And some of the medications do have some side effects. Patients will report lightheadedness. With Cialis, sometimes patients will report headaches. With Viagra, sometimes they will get the blue vision. So depending on the side effect profile, we may change the medications. Often what I run into with patients is the cost of these medications. So we have a lot of specialty pharmacies that we use that can help us provide these medications for patients. GoodRx is a great outlet for patients if the cost of these medications is high. And usually Costco and Ralph's also have some good deals. So what I always have my patients do is take the medication on an empty stomach, 90 minutes without any food. Don't drink alcohol. And then you need some sort of sexual stimulation to see if the medicine's going to work. And I usually will have the patients do at least 6 good trials like that of the medications. And then if that doesn't work, we're going to move on to different things. So what else can you do? You can do actually a ultrasound therapy for penile rehabilitation. And it's almost like a shock wave therapy that you're shocking the muscles, nerves, and blood vessels around in the penis to help them fill with blood and to initiate erection. You can also use a good old-fashioned penile pump. And I know we make fun of this, from the Austin Powers movies, but the penile pumps work really well. And a lot of times I will have patients who, I will actually, even before their prostate surgery, have them using the penile pump. And so the penile pump works by, you put the pump on, it pulls the blood into the penis, and then you put on a ring around the base of the penis to keep the blood in. So, but again, this can work very well in certain settings and provide patients good erectile function so that they can have sex again. There's also a urethral suppository, and I know that sounds strange, but it's a little tiny suppository that goes into the tip of the penis where the pee comes out. That's the urethra. And it kind of melts away. And inside there, there's actually drugs that help to initiate the erection, again, opening up the blood vessels, allowing the blood to come in and causing the erection. You can also do direct penile injections, and those are really in 2 forms. And I'm going to present some data on Botox used for penile injections for erectile dysfunction, as well as actually the medication. We call those intracavernosal injections, or ICI. And you can inject the medications there's 3 or 4 of them that we can use. We can put them together in different combinations. You can inject them directly into the side of the penis, and that can cause direct opening and stimulation of the blood vessels, and then the patient will have an erection. And then the last one, if none of the other things that we've done have worked, we can always do penile prosthesis, and I'll show you a picture of that as well. So this is the ultrasound therapy that I was talking about, and the injection therapy. So here we are actually putting an injection into the side of the penis. Again, sometimes that could be Botox, or that can be medicines like in relation to like a Viagra or Cialis that can go directly into the penis. And because you're injecting right into where the blood vessels are, they tend to work rather fast, so within 10 minutes. The shock wave therapy, as you see here, it's basically like an ultrasound machine, and they use a tiny little wand, and it delivers a very low level shock. Like it's not uncomfortable, it's not painful. And when you create this inflammation by the shocking, it stimulates the return of the blood vessels and encourages the blood vessels and nerves to regenerate. So if you're going to do a therapy like the ultrasound therapy or the shockwave therapy, in general, you're going to have to do it more than once. You may need 6 treatments in order to get the desired effect. On the upside, it's like I said, it's not very painful. Patients tolerate it very well. It's something that you can just do in the office, but it does require more time to work. The Botox, actually, I'll present the data on that. That's kind of the same thing. You have to do the Botox injections and kind of wait for things to adjust and to see the desired effects. So Botox therapy is relatively new. And so what I'm showing you is a graph of the people who got different doses of the Botox versus the people, the controls that got none. And you can actually see the scores of the people who got the Botox had better erections than the people who didn't with the controls. And that's what those numbers are. There's a scoring sheet that we use to say, okay, how good was your erectile function after we did the Botox? So this is widely going to become a therapy, and we're going to be doing some trials here with the Botox at St. John's in patients that are going to have prostatectomies. Let's talk about penile prosthesis. So this is actually where we do a surgery to give you a device that simulates an erection. We always tell patients, think of the penis as inside the penis, there's a cylinder. And the cylinder is a container that fills with blood. This is what gives you the erection. So we can actually insert cylinders and then fill them with fluid. So what happens is inside the belly, you have a little reservoir of fluid, and this is surgically implanted inside. Now the fluid from inside this reservoir gets pumped by the patient. Now the pump is in the scrotum down here. The patient pumps the pump, the fluid is brought from the reservoir into the cylinder, and the cylinders become erect. And so they're filled with a saline fluid. Then the patient can have sexual activity, have intercourse, and when they're done, there's a button that you can actually press on the pump that releases the fluid back from inside the cylinder back into the reservoir. So now these devices often work very well. Most of the patients don't have any kind of mechanical failure or issues for 10 to 15 years in some of our patients. They're usually very specialized urologists that place these penile prosthesis. But again, if we have patients, they've tried medications, they've tried the injections, they've tried the Botox, they've tried everything, this is kind of the last stand for them to have some erectile function. Now, there are a lot of other reasons why men get erectile dysfunction despite just cancer, but I think I'm sort of focusing in that genre of patients of what we can do to help them. Patients that have diabetes, patients that have, cardiac disease. Oftentimes, if you get blocked blood vessels, what can happen is that, the penis can't fill with blood, and those vessels are so tiny going to the penis that it's very difficult to unblock them. So sometimes techniques like these are the only things that the patients may be able to tolerate. This is a harder thing for me to treat, symptom for me to treat in patients. And it can be on many scales. I mean, I have patients that have lack of sensation for not being able to pee. I have lack of sensation in the penis for sexual function, lack of sensation in the vagina, lack of sensation in the clitoris. So oftentimes, again, this is because of some combination of radiation, chemo, and surgery. It's usually a swarm of things all together that may have damaged the nerves. I really try to encourage acupuncture. I think it helps. I really try to encourage pelvic floor therapy. I would like to see if Botox also would be helpful in some of these patients. And there may be, even doing other treatments like hyperbaric to regenerate hyperbaric oxygen, like we talked about in the tank, to actually regenerate some of the tissues and the nerves could be helpful too. But this tends to be one of the more difficult problems for me to treat. And it's usually a combination of therapies. And it's a journey for the patients to kind of get the nerves back online. What about bladder and bowel incontinence? Again, this can often affect patients' quality of life, their sexual functions. So if a patient comes into me and they've had surgeries, procedures, and they're leaking urine, and that may be two types of leaking. There may be the leaking where they cough, they sneeze, they jump, they run, and they leak. That's called stress incontinence. That typically needs a surgery to fix that. That means the sphincter that's holding in the pee in your bladder is loose and open instead of tight and closed when you run and jump and move. And in order to fix that, you actually have to put a little supportive mesh underneath the sphincter where the urine comes out. You can do that in men and you can do that in women to help keep the urethra closed so that they don't leak with cough, sneeze, and jumping. And that's called stress incontinence. More of what I see in my practice is urge incontinence, meaning when the patient has the feeling to go pee, they cannot hold it. They are on their way to the bathroom and the bladder just squeezes without permission and the pee comes right out. During the normal other times, they can hold it. But if they get the urge, they just can't get there in time. And we actually have a diagnosis code called garage door incontinence, where patients are pulling into their yard. They see the garage door going up, but they can't even make it in the house before the pee starts coming out. So the first treatment in general for that is medications. There are about 14 different types of medications. So I may go through 2 or 3 types of medications with patients before we decide that they're not helping. There is an acupuncture therapy for that called PTNS as well, and that can be done in the office. It's a 30-minute treatment once a week for 12 weeks. And we basically put a very tiny little needle in the ankle and we stimulate the nerve near the ankle. I know that sounds strange. You're thinking, what do your ankles have to do with your bladder? But the nerves that run to the bladder are right near where your ankle bone are, and you can actually stimulate the nerves down there. It doesn't hurt. Your patients come in once a week for 12 weeks, and that's called PTNS. You can also do bladder Botox, and here's an image here where I can look inside the bladder in the office with a camera, and then I can use a needle to inject several spots inside the bladder with Botox, just like, people put it in their face. And most patients tolerate this very, very well. Takes literally about 15 minutes to numb you and about 5 minutes to do. And that can help with urge incontinence or leaking. And if that's not working, I can take it to the next level up, which is called a sacral nerve stimulator. Now, the sacral nerve stimulator is much like a bladder pacemaker, but it also can be used for bowel incontinence. So if patients are having bowel leakage, you can also use the sacral nerve stimulator. And basically, we take a tiny little lead and we implant it into the sacrum, into the nerves that go to the bladder or the nerves that go to the bowel. And what happens is as this little generator here that's also placed under the skin, just like a little pacemaker would be, stimulates the lead, stimulates the nerves, and can help with incontinence and with bowel incontinence as well. And again, this may be from surgeries, this may be from radiation. I also have patients that have never had surgery or radiation that still have such bad incontinence that they need something this level to help with the bladder. And it really does have about an 80% effectiveness. It may not make the patients absolutely perfect, but 80% of the patients see at least 50 to 60% improvement in their symptoms, which is pretty good. This is more of a surgical procedure, meaning that you have to implant the device like in an operating room to be clean. But hold on a second, sorry. But it, like I said, it does work really well, and I've had great results with it for patients. So thank you guys very much for your attention. I wanted to give you guys plenty of time to ask any questions. We do have, I'm a urologist at St. John's. We actually do have a sexual function specialist that works in our office. His name is Dr. Saji de Guzman. He really specializes in hormones and erectile dysfunction. Dr. Lisa Valle, she also is part of St. John's. She is a women's sexual health specialist in our area. Dr. Mehran Movasagi, he's another men's health specialist. He actually does the penile ultrasounds and some of the Botox procedures. And Dr. Lauren Kadish, she's a urogynecologist, and she can help with some of the procedures to, if you have a shortened vagina or if you're having a lot of vaginal pain. I also have a pretty healthy list of pelvic floor therapists that I do use, that I offer for patients. There's probably about 6 or 7 companies, so the patients will come contact me and I can set them up with pelvic floor therapy as well. But I hope that this was helpful, and I hope it gave you some things to think about as far as your health, sexual health, and as far as some options that you can do. I mean, I feel like sometimes patients are sitting at home suffering, and because they're too embarrassed to ask questions, or they don't even know that there are options available to fix the problem. So hopefully this has offered you some comfort. And if you have any questions, please let me know.
Thank you so much, Dr. Linehan. What a informative and meaningful presentation, and so much depth to the information. We really thank you. And we want to open it up for questions from all of you. So please feel free to go ahead and type those questions into the Q&A feature found at the bottom of the Zoom window. We did receive a few questions at registration, so I can start with one of those. Someone was wondering, is an overactive bladder a side effect of chemo and radiation? So if you could address that.
It can be a side effect of chemo and radiation. There are breakdown products that sometimes go into the chemotherapy that can irritate the lining of the bladder and can cause an overactive bladder. And then the radiation, like I said, it kind of slowly contracts some of the tissues. It destroys some of the normal blood vessels and nerves. And so that also can irritate the lining of the bladder over time and cause overactive bladder.
Thank you. Someone is asking, how effective is the vaginal laser if you've had radiation? And is this the same as the Mona Lisa procedure? She has heard, or not she, this individual has heard that radiation reduces the efficacy.
Reduces the efficacy of the Mona Lisa, the laser?
That's what it sounds like from the question.
Yeah, I mean, basically, if you've had the radiation before or after the laser, there's going to be some damage to the tissue, right? So the laser is not going to be as effective. That's why you might consider doing something like a combo therapy if the vaginal dryness is really intense, or there's pain with intercourse and the lubricants aren't working. I may actually have them do hyperbaric chamber and the laser, because that's going to give them a much more advanced regeneration of some of the tissues and reduce the damage and injury to the tissues.
Thank you for that. Another question is, if cancer treatment resulted in early or post-menopause, what can one do without taking hormone therapy to help with side effects?
It all depends on what are the side effects. So there are some very good natural treatments for hot flashes, night sweats that are not hormonal. And acupuncture can help with that. Like I said, if it's vaginal dryness, you can use the laser, you can use hyperbaric, you can use lubricants. The one that is more difficult to fix is libido, because libido tends to be a hormone-driven thing. But there are some sort of bioidentical hormones that sometimes they can play around with. Dr. Valle does a lot of that, that can help like re-stimulate the libido. But just depends on what symptom is really affecting the patient.
And then how long do those effects normally last if the individual treated was young in their late 30s when this happened?
So, I mean, if the effects of surgery, if you just have surgery, tend to be relatively short, because if you haven't had any radiation, hadn't had any chemo, and just have surgery, the nerves, the tissues generally will heal, especially if you're young, in a normal fashion. If you've had a combination therapy where you've had radiation and then surgery, sometimes the radiation causes damages of the tissue and the nerves, and with the addition of the surgery, they may not heal as well. That's why sometimes you have to do some of these secondary treatments to help get things back to normal.
Great, thank you. Could you speak more about the different medications that are used to treat garage door urgency?
Yeah, sure. So there are two genres. One is called a beta agonist and one is called an anticholinergic. Anticholinergics are actually like good old-fashioned Benadryl. There's various forms of them. Anticholinergics like Benadryl act everywhere in your body. The newer versions of these medications only act on your bladder. So they basically calm the bladder. They block a receptor on the bladder so that the bladder's not overactive and just squeezing at will whenever it wants to. The side effects with them usually can be a little bit of dry mouth, sometimes dry eye. With the older generation ones, sometimes even constipation too. The other genre is called beta agonists. They're relatively new. Again, they work by stimulating a certain receptor on the bladder to help calm the muscle of the bladder so it's just not contracting whenever it wants to. And that's when you're getting the urge. So your bladder contracts in your body to go, I have to go pee. And so sometimes the bladder just squeezes without your permission, and then the pee comes right out. So both these medications help to calm your bladder down by different receptors. The newer versions tend to have less side effects, but the problem is they're incredibly expensive. So, and sometimes I actually use a combination of the medications together because they work synergistically. Sometimes I have a patient who gets a medicine and we still do Botox, or they'll get a medicine and we'll still do the acupuncture. So there's a lot of different directions that you can go depending on how overactive the bladder is.
And then moving back to the topic of early onset menopause, what natural methods or herbs can be taken to help with hot flashes?
I think, obviously the one that's actually been studied the most, like in scientific literature, is probably yam. So any kind of yam extract and soy extract is going to be the most helpful. Although there is some literature to suggest that soy is not the best. But the yam extract, and I also found pumpkin seed can also be very helpful. What I do tell patients about any kind of supplements you take is that supplements take a long time to kick in. You will not see results from a supplement sometimes for 3 to 6 months of chronically taking it. It's not a medicine, it's a supplement. So it takes some time for the medicinal component of the supplement to actually function and work. But those are usually the most common, some with the soy, and you can actually take a de-estronized type soy, you can use a yam variety, and you can use pumpkin seed.
Thank you for that. And then we're going to shift a little bit into just advice for how to speak to a provider. So someone is asking, how do we get our providers to be brave enough to try hormone therapy, specifically vaginal estrogen after breast cancer? I keep seeing and hearing through these webinars and reading studies that it is a very low amount of hormone, if any, that enters the bloodstream, and yet providers still have a better safe than sorry approach. So advice for this individual.
So, I think one, this is a discussion between you, your doctor, and like I said, the medical oncologist. Like oftentimes the patients will see me as the urologist, right? But I'm not treating the breast cancer. So I got to call the medical oncologist and say, look, she is miserable. We have got to do something. Can we just try a little bit of this? There are different versions like Vagifem that are like the little tablets. We'll try a very low dose. So I think it has to be your doctor sort of being your advocate to another doctor saying, listen, we really need to try this. It's easier in the office just to say, oh, don't do it. It's too safe, or, it's too scary. And I get that. And I get why physicians do that. But the patients are sometimes just really uncomfortable. And I think that has to be a better discussion and physician understanding that, listen, I'm at the point where I need to try anything, because right now I'm so uncomfortable, nothing else matters. So, and I do have a lot of patients that are in that boat, and we try to work together as a team to provide them with some more treatment options. I mean, my favorite quote is, patients don't fail treatments, treatments fail patients.
That's important. Someone else is asking, it's really a twofold question. Do you provide vaginal laser in your office? And then do you refer out for the hyperbaric chamber treatment?
Yeah, I do not do the vaginal laser in my office, but there's tons of offices in Santa Monica and gynecologist offices that do it, but I don't do it in my office. And then the hyperbaric, there are some private offices in Beverly Hills. There is UCLA has a big tank that they put all the patients in. Most of the bigger universities will have a tank, and then there's some private offices in Santa Monica and Beverly Hills. To be very frank about it, my experience is that the bigger institutions, I have an easier time getting them to take the insurance because the treatments can be expensive. With the smaller places where they have the single tanks, the patients generally have to pay for the treatment and then bill their own insurance, which tends to kind of be a pain in the butt. So I definitely whatever's easiest for the patient is what I'm going to do, but you have to refer them to those centers with very specific criteria to get insurance to pay. I mean, anyone can just call them and make an appointment, and they're probably like $300 for a hyperbaric session. But like one session is not going to work. You need multiple sessions to actually reap the benefits.
Then can you talk a little more about Prudence injections, and is it good for dryness and pain?
Do you mean pudendal injections?
I think that's correct. Yes.
Okay, so the pudendal injections definitely can help with pain. They will not help with dryness. Two different things. Basically, you're numbing the nerves down there. Maybe sometimes, like I said, adding a little bit of steroid in there to help calm whatever nerve inflammation is going on. So definitely the pudendal injections can help with pain. Sometimes I'll see patients, one injection was enough, and some have needed like 4 injections over a time period to make a difference. But since you're actually numbing the nerve that goes to the sensation, not only in the tissues, but in some of the organs as well, that's what can cause, the relief from the pain. And sometimes it's, maybe only the last couple of days, and sometimes we get a much longer benefit.
And then this is another question along the topic of vaginal dryness. You mentioned vaginal coconut oil. And are there specific brands that you recommend individuals purchase?
No, I don't. There's not specific brands that I quote patients, but just make sure that you're not buying a cooking coconut oil. This is usually a coconut oil that's in the personal health section of Whole Foods or a vitamin store. So it's made in a sense for skin, and it's made to go inside the vagina if needed. So there are several different types of it, but I have had patients make the mistake of buying like the cooking oil type. So you have to go searching out, personal lubricant coconut oil.
Great, thank you. And then can you talk a little more about how chemo treatments affect the pelvic floor?
So chemo treatments can affect the pelvic floor in multiple different ways. So just like chemo can give patients neuropathy in certain areas, you can get neuropathy within the pelvic floor. Like I said, you can get the breakdown products that can irritate the lining of the tissues. So for example, how would that work? You would get irritation from the chemo breakdown products in your bladder. Your bladder starts to spasm and contract because it's irritated. It thinks there's something inside it that it needs to get out. That chronic kind of spasming causes tightening of your pelvic floor. And now we have a tight pelvic floor, a spasming bladder, and the patient's just generally uncomfortable. So it's not sometimes like the chemo is directly causing that effect. Sometimes, yes, it could be irritating the nerves, but it's usually sort of a combination of the breakdown products that are causing some dysfunction somewhere else that are causing dysfunction in another place. So like I said, you might be getting irritation in the rectum. And so that'll cause spasming in the rectum that again can cause tightening in the pelvic floor. The fascia get tight, the nerves get pinched, and then the patient's uncomfortable. So there's a variety of different ways that actually chemotherapy itself can cause irritation.
Great, thank you. And then we have one final question. Someone is asking, what is being investigated to decrease surgical margins, and is there a role for artificial intelligence in decreasing those surgical margins?
Yeah, I mean, it really depends on what organ system you're talking about. We do have an intraoperative dyes you can use to see where your surgical margins are. Basically, some of the dyes will light up in certain cancers and not in normal tissue. So you can sort of know where your margins are. As far as artificial intelligence, there are techniques called optical coherence tomography, where you're basically using this very tiny little wand to almost microscopically look at the tissue while you're on the inside. So you're getting a microscopic view, and you can use that view to delineate where the normal tissue is and where the cancer tissue is. The problem is getting this equipment and getting these technologies into practice is incredibly difficult. A lot of it just takes a lot of money to actually put those mechanisms into tools that we use today. And that's usually some of the biggest holdup. But I don't know if that would qualify as artificial intelligence, but maybe one day I could see one of those scopes that we're using to look at things microscopically would be feeding back into a system that was using artificial intelligence to help you identify which tissue is cancer and which tissue is not.
Great, thank you so much. We've had wide-ranging questions and appreciate you answering all of them and digging deeper into the questions that we had from the information you presented. And Dr. Linehan, I want to thank you today for your time and for sharing your expertise with us. I want to thank those of you who have joined us today and for your engagement with us and participation and thoughtful questions. If you have questions for the cancer support community at Los Angeles, you can email us at info@cancersupportla.org. And that's going in the chat. And again, it's info@cancersupportla.org. And if you'd like to learn more about our programs and services, you can visit our website at cancersupportla.org. And that is the end of our time together. And we thank you one and all for coming today. Take care.
Thank you very much.